This podcast is being recorded on the lands of the Wurundjeri and the Bunurong people of the Kulin Nation. We pay our respect to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders, past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This episode is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced, evidence-based discussion. When medication is mentioned, we'll use the generic name unless referring to a medicine listed on the PBS, in which case we'll use the commercial name. Please note that availability can vary between Australia and Aotearoa, New Zealand.
Welcome to another episode of Talking O&G, a RANZCOG podcast where we take a closer look at the latest clinical guidelines, research and topics in obstetrics and gynecology through conversations with leading experts. Informed consent is something we engage with every day in clinical practice. It's embedded in nearly every patient interaction, from routine consultations through to complex procedures and decisions. But while it's a familiar part of our work, it can be easy to slip into seeing consent as a process of formality rather than what it is fundamentally, a shared decision-making conversation that supports patients' autonomy, understanding, and choice. In this episode, we revisit what informed consent really means in clinical practice, why it matters, and what our professional responsibilities are as clinicians. RANZCOG has recently released a new signposting guideline, consent and provision of information to patients regarding proposed treatments. This is designed to support members and trainees in navigating discussions. This guideline consolidates and replaces the previous RANZCOG clinical guidance statements C Gen 2A and C Gen 2B. Today we'll unpack some of the fundamentals outlined in this updated resource. I'm your host, Dr Vijaya Karanam, and I am an obstetrician based in Melbourne, and I am a committee member for the Victorian RANZCOG branch and SIMG and Research Guidance and Policy branch of RANZCOG. Today we are joined by Dr Penny Sheehan, Deborah Pidd, and Yvonne Maringa.
Hi everyone, my name's Yvonne Maringa. I'm a mental health nurse and social worker. And in terms of what I bring to today's conversation, I bring the lens of the consumer. I am the proud mother of two amazing boys. And I've also recently been receiving treatment for adenomyosis.
My name's Dr Penny Sheehan. I'm an obstetrician from the Royal Women's Hospital, and amongst other things I've been doing, for the last 3 years I've been the clinical lead for the maternity and newborn improvement team at Safer Care Victoria.
And I'm Deborah Pidd. I'm a midwife. I've been a midwife for a long time, but I've mainly been specialising in antenatal care for the last 30 plus years. I have spent a lot of my career supporting women. I'm very woman-centred. That's my whole practice. And I've just submitted a PhD, which is on just how maternity care can better support women, a women-centred focus. I do work in the public system, and I'm very really interested in this topic. I think it's a great conversation for us all to have as a multidisciplinary group of people. I think it's terrific.
Thank you. Congratulations, Deb. Before we begin, does anyone need to declare any relevant conflicts of interest?
I have nothing to declare.
Okay.
No conflicts of interest from me.
Good. Let's start then. Let's start with what good practice in informed consent looks like. The signposting guideline outlines 5 key principles. Penny, can you walk us through these, please?
Sure, Vijaya. So from the RANZCOG guideline, the key principles are providing information on patient care in a way that they can understand. And of course, although that's a simple phrase, there's a whole lot in there about the patient's background and their literacy and their language and their culture and so forth. So it's actually quite a complex point. Providing an opportunity to consider and discuss the information with you, and that providing an opportunity to consider, you should also think that potentially is providing the opportunity for the patient to go away and consider the information that you've been given, which is another critical point with it. The next point is about the patient who doesn't have capacity to give informed consent. And it's critically important that we all as clinicians understand what constitutes capacity and how we can assess that. And certainly for those of us working in the public service, the assessment of capacity usually involves a multidisciplinary team. There are people who can help and support you. Neuropsychology, psychiatry, there are usually ethics committees, senior staff should all be involved in that idea. The next point is something that as a primarily public hospital person, I was surprised by, but it is also relevant for the public hospitals. So the next point is about ensuring the patient's informed about potential costs. And although that might seem more a private practice issue, in fact, there are so many more extra costs involved in public care these days, and particularly for our women who are non-Medicare. It's essential that they understand what costs are going to be involved even in attending a public hospital. The last one is about being respectful and supportive of the patient's right to seek a second opinion. And of course, they should, you should welcome the opportunity for any kind of contentious situation for the patient to go and see someone else and hear a different point of view. So those are all from the RANZCOG guideline, and I just point out that Safer Care Victoria has recently published a respectful maternity care framework, and we can add a couple of points for good practice from there. So this Safer Care Victoria framework borrowed heavily from the RESPECT framework from Queensland Health and uses RESPECT as a mnemonic, the RESPECT, and no, I don't think we should sing it. I don't think this is that sort of podcast. The R is recognising the woman's right to decide. E is enlisting appropriate interpreters when needed, and interpreting can be critical. S, sharing balanced information. P, providing time and space, and we talked about that before. E, enabling questions, so giving women, the right and the permission and the space to ask the questions that they need to ask. C, checking for understanding and, of course, agreement. And T, trusting that the woman can make her own decisions, and that's a point that I'm going to go back to, I think, throughout this talk. Sometimes it can be hard for clinicians, I think, to trust that the woman will make her own decisions and accept consequences of her decisions. Lastly, I'll just add that patients can withdraw consent at any time. Now, that can be a really complex situation, but it is worth recalling. And even when I think we've all been there where we're task-focused and we're so close to completing our procedure, whatever it might be, a forceps to birth or a minor gynae procedure or suturing, and suddenly the patient says, stop, no. And it can be so hard to take that back and say, no, just another couple of minutes and we'll all be finished. But if the patient withdraws her consent, she withdraws her consent.
Can you talk us through different types of consent and explain our responsibilities in terms of when and how consent should be obtained, Penny?
So again, from the guideline, the need to obtain informed consent can be required at different stages over the course of a treatment pathway and even in different stages of a consultation or examination. So, of course, a person can give consent in writing or verbal consent, or consent can be implied. But I think with implied consent, my own thought is that you should always just stop and check for ongoing implied consent. So someone may appear to consent for a examination, for example, but it's always wise to stop at various critical points through the examination and say, are you happy that we continue? The most appropriate form of consent depends on the degree of risk and complexity of treatment, of course. So, we usually ask verbal consent for just an examination, whereas clearly for any kind of procedure, we want written consent. Clinicians have a responsibility to know and understand the legal obligations of the state in which they are practising. And we talked before about the assessment of legal capacity, which is also a critical part of obtaining consent. Then there's also the issue of what happens when a person has been assessed as not being able to give consent. And there, clinicians have a responsibility to understand what they should do and what steps can be taken and what substitute decision makers are available to them.
Deb, how does this work in real-world practice? How do we obtain valid, informed consent?
Well, the real point I want to make, and so Penny, that's a fantastic outline of all the legal and, really important kind of foundations of it. But the other thing that's so important is actually it's a relational thing. It's not a transaction. It's not exchanging or even kind of pouring information to somebody else. It's actually really about a conversation where there's a build-up of trust, and that's established actually by, in the first instance, the clinician, be it an obstetrician or midwife, actually finding out what's important to somebody. Depending on the circumstance, and as I've said before, I work in antenatal care, but I think that's where the foundation of building that trust and the relationship comes. And I think, it's obviously more than just writing in a bit of paper and making sure that you tell somebody everything. It's not kind of like a shopping list of things. It's really about understanding what's important to a woman. So, for an example, you might have a woman who's got a very low threshold wanting to have a caesarean, say, whereas somebody else may have a very, very high threshold. So consent is different for different people. So we need to understand what's important to an individual, what information is that she wants. So I guess the information is not a one-size-fits-all. It's about what's really important to that woman and having a genuine conversation about that, listening. At the heart of most of the things we do is our job is to listen and provide information that's appropriate to that situation. Continuity is really, really important. But if you're meeting somebody for the first time, as I think Penny would attest to, understanding what's important to that woman, you can establish a relationship quite quickly if you have taken the time to read the notes and speak with the woman. And I think those things, that building of trust is absolutely pivotal to good informed consent.
What does good informed consent communication looks like and feel like for patients? Can you talk about consent that feels patient-centered and respectful from the consumer perspective?
I really love what Deb said about consent being really relational, and I think it's really important to remember that it's not a legal requirement. It is very much a human experience, and I think bringing in that human aspect to consent is really important. It's also really about feeling that you've been informed about what's happening, that you're feeling respected, that your views are taken on board, that you feel listened to. But it's also really about safety and knowing that you are feeling safe with the person in front of you, that you have a shared objective, which is in, I guess, the example of obstetrics, it's the safe delivery of the baby, and that you have shared interest in achieving that goal successfully. It's really grounded, I guess good consent is grounded in trust and mutual respect, and the trust builds up not at the point of the child being delivered, but when the client first comes into care. It's those micro moments you have with the person who's at reception. What's their response been to you? the cleaner who comes into your room. So it starts in those small moments, and that's what builds a patient's trust. Because suddenly, you find yourself in a situation where you have an obstetrician or a clinician in front of you, and you're trusting them with your life and your child's life. So it comes with significant vulnerability, and I think if clinicians are approaching consent from the perspective of they are being trusted by somebody who is incredibly vulnerable to work together. So it's a partnership to safely deliver a baby. It's really respectful in its language, in its tone, in its behavior. So it isn't about, I think as Deb spoke to, ticking boxes. And I think clients can always, they have a good sense of trust, right? Then that relational aspect of, okay, I'm going into this situation, I'm about to have this baby, I don't trust the person across from me. And what does that do to that family's experience of bringing a child into the world? It really looks like clear, honest, and jargon-free communication, meeting the patient where they're at. Some patients will require a lot of information, and it's pegging that information where they're at. Others are very data-driven. Where's the evidence coming from? Provide them with that information. Others want the bare minimum. Tell me what I need to do, how we're going to do it. So it's really individualized. It's not a one-size-fits-all, as Deb said earlier. And it's also about providing real choices and alternatives. And I think a question that always comes to my mind when I'm thinking about, somebody providing options to me or recommending a particular choice is, if I was your loved one, if I was your sister, would you be giving me these same recommendations? And I think if the answer is no, then there's something there that really needs to be addressed. Because why? Have you presented me with less options for a reason? Is there a particular reason that perhaps you're being driven towards a particular decision? But it's also really about acknowledging the cognitive load that women come to when they're having that conversation. Deb talked about allowing time to ask questions and process that information. And when I think of my personal experience with my second son, this was right in the middle of COVID. And I think there was an assumption, because it was my second son, that, well, she's been here before, she knows this. It had been almost 5 years. Not only had I completely forgotten everything, but also I had such high anxiety. What's going to happen to my baby, right? COVID, we don't really know what's happening. What if he gets infected? What if I get infected? What's that going to look like? So much uncertainty. So in that moment, being presented with lots of information, not enough time to process it, that wouldn't have worked. And I think I'm really, really fortunate that I did have a great obstetrician and a great experience where, because that relationship had been built, she was very much aware of my anxiety. She took time to really explain my options and give me time to ask questions. And it wasn't a one-time conversation, so she would come back to it and remember what we spoke about. Are you still okay? Should we proceed with the plan as we agreed? So it was a rolling conversation as opposed to a single conversation. But most importantly, it really feels like being heard and taken seriously, feeling that your previous experiences are not being minimized, they're not being diminished, they're not being dismissed or ridiculed, that every question is a worthy question that deserves to be answered appropriately. And particularly in the instance of bringing a baby into the world, it's such a beautiful time for a lot of families. And I think good consent looks like a good relationship, is really what it looks like, a good partnership, where we're coming together and really wanting the best outcome.
Deb, drawing on your personal experiences, what works well for you in these conversations?
I think the building of a safe environment. When we talk about these things, we're spending quite a bit of time on this, but actually it's time well spent. Time well spent actually really getting to understand what a woman wants and spending that time with her actually will save an awful lot of time and angst and concern further down the track. So it's time well spent doing that. As I said to you before, I think consent should be occurring, the understanding of consent, and really the understanding for a woman to actually understand what her rights and to help her advocate for herself, and not for us not to have an agenda. Our agenda should be to be able to listen and understand what's going on. I'm an enormously big fan of in Birth Suite that I think, and we're going to talk a little bit more about the team, but I think it's so important, regardless of risk, is that that all the team who are going to be looking after that woman actually meet her and come in as a conversation from a human-to-human perspective. Hi, I'm Deb, blah, 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 or, like for the doctors. And I think another really important thing is to recognize, you'll only, sometimes the docs, everybody's fine here, you'll only see me if something goes wrong, which is actually a crazy thing to say, because actually it should be, I'm here. If you want to speak to us, we're here, we're available, because what you're wanting to do, which Yvonne was explaining, is that you're wanting the woman, and this is from a neurobiology point of view, is you want her prefrontal cortex to be working really well. And how that works well is if you've got a safe, calm, trusting environment. So the amygdala is feeling, I'm safe, there's nothing to worry about here, so can be more present, because, of course, being in labour and making decisions is inherently anxiety provoking. So for us to be able to create a beautiful, safe, calm environment actually benefits us all. The other thing is, because we all are human, people have a different perception of risk. It's very individualised. We have to be very careful. We have to be reflexive ourselves about what anxiety or concerns we bring. We've all had, those of us who've worked for a long, long time, we've all had different experiences, and we can bring, we sometimes worry, and that is our job to do that, but also our job is to just also try and bring a calmness. This is a different situation, so we all benefit from, we should all probably do calm birthing, like in terms of from a clinician point of view, to take some breaths and just be in the present moment. I think that's a component that's really important. And the other thing is, which speaks to what you were talking about, Yvonne, about control and choice, we should always have, if somebody doesn't want to pursue something that we might recommend, well, what are the contingencies? What does that look like? Giving women control and choice genuinely, and genuine information about the risks rather than a blanket statement. It's not up to us to choose somebody else's risk adversity. It's for them and us to listen to what that is and put contingencies around that, because we want to do the best by the woman, and we also want to sleep at night, and we want to make sure, you know what I mean? I mean that in terms of that we want to feel, but that's where we have to be very, very careful that we don't overlay our anxieties, and where that can end up being like a soft coercion, we have to stay hard as it is. And I think we've got a beautiful framework now, which I think is such an important, we've got a framework that we can work with that helps us do that. So that all sounds a bit time consuming, but actually I think the important point is, if we can create a safe, calm, respectful environment,
it is worth the time.
It's worth the time.
How can clinicians better tailor consent conversations for patients with different levels of health literacy, language needs, cultural backgrounds, or previous trauma.
We talked a bit about avoiding jargon here, and I don't want to trot phrases out that sound like jargon, but cultural competency is a key skill for all clinicians in O&G. And just to put that in perspective, it's got a whole lot of different aspects. There's an awareness component, so just understanding how culture influences a woman's health and her choices and her understanding. Not to say that you necessarily understand all cultures, that's a ridiculous ask, obviously, but just that you understand how important culture can be. Sensitivity, so at the same time as understanding the importance of culture, showing respect for different cultures and different beliefs. Ideally, being able to communicate in ways that are culturally responsive and appropriate. And, sometimes that might not be possible, but certainly more and more services are trying to put culturally responsive I'm using the word services again, but they're trying to put those aspects into their service. This all applies to different sort of backgrounds. So we have our First Nations women who have all sorts of different cultures, actually. They're not, the same First Nations culture. There's quite different experiences amongst First Nations women. And they have a particular set of issues and backgrounds and experiences. And then we also have migrant women and then our refugee women to consider in this context. Some of the key supports include early identification of language needs. So if someone really does need interpreters, it's key that they are there and available. It's very important that our interpreters are appropriate interpreters, obviously. I myself, I've worked with some great interpreters over the years who I've really come to rely on. On the other hand, I've had some less than perfect interpreter experiences. I can think of the time when I was doing a pregnancy loss counselling and the interpreter, who was a telephone interpreter, suddenly said, I'm being breathalyzed, I'll just have to pause for a moment. And clearly, that was a bit of a low point in the whole conversation. On the plus side, at least, there was an interpreter there. And, you do have to think sometimes about with the interpreters, is the interpreter doing the right thing for the woman? So sometimes it is worth stopping and saying, are you comfortable in this setting? Unfortunately, for some of the really small ethnic groups that we have, and I think that particular interpreter in that case was Zomi Chin, and it's very hard to get a different interpreter, but sometimes it might be worth considering if you're not feeling that this is working well, maybe I should just hang up and request a different interpreter or bring the woman back at a different time. Training of our clinicians and continuity of interpreter service, clearly those are aspirational things that we all hope for in the future. Health literacy. So considering a woman's health literacy is quite important, and it's important to be able to try and provide your information in different ways. We all learn in different ways. We understand things in different ways. So pictorial representations can be helpful, and sometimes discussing something like bicornuate uterus, I rely on Google Images to pick certain images to show them when I can see that the conversation, just the words are not quite getting through. Describing risks in different ways is also a challenge. We all think about risks as in 1 in 1,000, but I think a lot of people have problems interpreting what does a 1 in 1,000 risk really look like and what does it mean for me. And I think my experience is that lots of women, if you say this is a 1 in 10,000 chance, it automatically interprets for them to this will not happen to me. But in some cases where that 1 in 10,000 chance is drastic, I think you do have to spend a moment to say to them, so just, that it's unlikely, but if you were that 1 in 10,000, what would this mean for you? Sometimes it's helpful to relate your risks to everyday situations. So I think many of us will have seen John Newnham's great talk with the Preterm Birth Collaborative about what that early preterm birth means in the context of the school child. So, he talks about how if we deliver X% at 36 weeks, what will that look in 5 years and 10 years like with more children at school with various problems. And I think that those sort of translations really reach people, as opposed to just the background, you've got X% chance of the child developing this. Using prepared printed information can be helpful. These days we're all giving women QR codes, and my experience is that they're not necessarily checking the QR codes. I think lots of women like to walk away with something tangible to hold on to after appointments, and I think RANZCOG has lots of patient information sheets. I think using things like that are helpful because they're authorised translations in many cases. So Google Translate, we all know, is great when you're trying to navigate your way around a foreign city, but probably not appropriate for consent and really giving information. And lastly, there is the comment there about women with previous trauma, and I do think there is a lot more work to be done on clinicians gaining experience and knowledge in the area of trauma-informed care. I've also heard about it being renamed as healing-informed care, so that you focus on hopefully the positive that's going to come out of it rather than keep bringing up that past experience.
So numbers need explanation. Thank you,
They
Penny.
do.
Thank you. Yvonne, not all patients need or process information the same way. It's important to ensure that through genuine curiosity, clinicians understand their patients, their hopes, their values, and meet them where the patient is at. It's not a one-zone-fits-all situation, isn't it? So what do you think good consent adapts to?
I think it's, again, really about meeting the patient where they're at. And I really like what Penny was saying about that patients prefer to walk away with something tangible. And part of it is about allowing that time to process that information, because a lot of things are happening in an appointment. There's a lot of fear, perhaps there's a lot of anxiety, and in that moment, it's very difficult to bring up any questions or even to process that information. But when you take something away, you're able to actually go home, have a read, and really understand it, hopefully with the opportunity to bring up questions at a later stage. But also really looking at patients who come from different cultures and looking at their cultural needs. It goes back to that relational piece, really. And if we have a sound understanding of who our patient is, it makes it so much easier for the clinician, but also it makes it a safer environment for the patient. And Penny talked about cultural competence, and I loved that she sort of ended that as, well, you're not going to be competent in anybody's culture. And I love the notion of, cultural humility, which is accepting that the patient is the expert of their culture, because culture is dynamic. And it can be very easy to assume that because patients come from a certain cultural background, that their beliefs are the same, but that's actually not true. And that's why that relational piece becomes so important, because what matters to you? What's important to you? What do you want this birth to look like? But also still, and I really want to emphasize that relational piece, thinking about the trauma. So if we know that the patient has had, previous traumatic experience, we're asking those questions. So I see you've had, a previous delivery. Can you tell me about that delivery? What were the good aspects? What would you like to replicate? And what would you like us to avoid where possible? And I think even if The perfect delivery, which doesn't exist, I believe, cannot ever happen for the patient. The fact that those questions were asked is really, really important because what it shows interest and that partnership. So it's saying you had a previous bad experience or traumatic experience, and I don't want this experience to be similar. And I think that really is what cements that relationship and that trust.
The 2026 Asia Oceanic Congress is being hosted by RANZCOG in Sydney from 12th to 15th of October. The theme, Equivolution, will cover topics such as sustainability and equitable healthcare for women of all backgrounds. This is your chance to be part of our region's largest O&G event in decades, meet international experts, and hear about innovative research. And of course, take the opportunity to enjoy Sydney's stunning nature, food, and culture. Visit aofog2026.com to learn more.
Now, looking at some of the more challenging scenarios, Penny, how should clinicians respond and approach consent in situations where the patient's preferences differ from recommended care?
Yes, so I think lots of staff in maternity really struggle with this, and it's really they're struggling with some of the personal aspects of this situation because obstetricians and midwives are people too. In my experience, the majority of staff genuinely want the best for their parturients, right, for their women who are labouring and delivering. And they might feel a variety of different emotions when they perceive that their advice, their experience, their expertise is being rejected. And Deb, you talked before about we all bring our own lens to things. Mm-hmm. So we all know that when we've just had some terrible outcome, we tend to bring that experience to our next few births because it's fresh in our minds. It takes a while for that for us to recover. I think staff really have to allow for that and be aware of that in themselves. For junior staff, there's an additional overlay here that they fear being seen to have failed in obtaining consent or, in the woman conforming to what is expected. We need to make it clear that that's not the case. It's not a failure. Even when I've seen someone who is determined to take a course that I am uncomfortable with that risk of, I often think to myself, gosh, maybe someone else could have brought it up in a different way. Maybe someone else could have had that, maybe for another practitioner, that conversation could have gone in a different way. And what did I do that ended up in that discussion? And obviously that's, it's clearly not me. Most of the time I discover that the next person they've talked to, she's said exactly the same things. But we all have that feeling of, did I do something in this conversation that led to her making perhaps what I might see as a dangerous or risky choice. I think that can lead for junior staff to a certain degree of anxiety, and then the conversation can go in quite a different way because the woman picks up on their anxiety to get them to agree to something that they don't want to agree to. And I think that the solution there for the junior staff is to escalate. Senior staff understand all about these sort of conversations and they don't see that you have failed in any way. I think that we have to go back to the principles of shared decision-making when we're talking about this. I think, it's important to present the information around why we are giving the advice that we are giving in a straightforward, factual way, acknowledging the limitations of the evidence that we are using. I think it's also important to explore the implications of decisions. Sometimes women will make decisions that you think that you can foresee down the track will cause a lot of trouble. So, and the women may be focused more on those immediate outcomes. So, for example, a woman who doesn't want the induction that you are suggesting, then talking to her about, all right, how does that look for you in a week? How does it look for you in 2 weeks? Where is the limit of that decision for you? Reaching compromise where possible is great when you can, and carefully documenting your discussions where agreement can't be reached. And this is the other thing I went back to before about trusting women. So you sometimes have to accept that women will take responsibility for their decisions. That sort of trust is often difficult. I think that's what a lot of clinicians struggle with. They say, well, what's she going to say? If this all goes wrong, as I foresee it could, she will come back to me and say, why didn't you stop this? But I think that, you have to come to a point where you trust that the woman has been informed and that she is making her decision.
It's always a complex situation. Thanks for explaining that. In labour, birth and emergency situations, circumstances can change very quickly, as we know. Penny, how can clinicians approach obtaining consent in an environment where decisions need to be made quickly and under stress, and urgency may make informed consent more challenging to achieve?
So when I looked at this question, the Respectful Maternity Care Framework has quite a good list to follow, and I'm just going to go through that. The key, inform the woman, so staying informed all the time, even though things might be changing quickly. Sometimes this is challenging. You've got lots of demands. You're trying to run an emergency, but it's always worth taking just a short period of time out to say, this is what's happening and I'm trying to organise these things. It often really changes the atmosphere when you've just taken that time to inform the woman of what is happening. Trying to provide continuity of carer, so where things are not going well, having the same person present for a period of time. We all know continuity of care is so important. Respectful, effective communication. So communication is key. Protect the woman's environment, so reduce the number of clinicians in the room. And certainly, when a code has been called, there's a number of helpful people coming to see you and you are glad to see them. But for the women and their partners, that's often part of the most stressful component of it. So when the initial assessment is done, asking people who aren't necessary to go back to their everyday tasks is often a key. Preparing for immediate action, so ensuring that the multidisciplinary team, you may ask them to step outside the room, but ensuring that they're still really accessible. And, we've certainly, I can recall being there with a woman with severe HELP syndrome who was declining care, and the number of MET calls that we called and the ICU team would attend. And at one point the ICU team did ask, should we just not come because she's not accepting any of our suggestions or any of the things that we were offering, but we said to them, no, we still need you. We still need your support. And eventually, of course, it came to the point where we absolutely needed them to leap into action. So I do think it's really important that the team is still there, although they might find it somewhat frustrating. Engaging senior leadership, and I talked a bit about that before from the junior staff perspective. You do not need to manage this alone. Please call, escalate it to whatever your appropriate escalation process is, and most services will have an escalation process. And finally, documentation. Allocate a scribe, so make sure that someone is writing it all down.
Yvonne, what helps patients feel informed, respected and safe in these high-pressure situations? And how can clinicians help reduce the risk of patients developing trauma from these experiences?
I think it's really important to remember that trauma can occur not because of outcomes, but because of how care is delivered. And when we're thinking about the situation that Penny was talking about, where suddenly there's multiple people in the room trying to get consent from a patient at that point, the optics of that, right? There is several professionals, clinicians, it can really feel overwhelming, to feel as though you are having your choice taken away from you and you have to be steered in a particular direction, and that you don't necessarily have any other options. But when communication is clear and calm, and Penny talked about particularly in stressful, high-stress situations, despite sort of managing all these competing demands, being able to have that conversation with that woman. So saying, look, this is what's happening. This is what we need to do right now. That's such an important piece, because I think what that reminds the patient is that I'm still here. I'm still invested in this process with you. I'm still invested in this partnership of us delivering this baby safely together. And I think particularly where things aren't necessarily going right, it just helps to demonstrate that commitment from the clinician that you are still working towards a shared goal. Penny also really pointed out about, protecting the woman's environment. Love that. I absolutely love that. Because you feel incredibly vulnerable. And in that moment, there are several different people in the room. You feel even more exposed. And so who needs to be in the room at that point? And is it necessary for them to be present whilst a particular examination is happening? But really also something that I think is important about providing that information and making sure that the support person is present. Because sometimes you're in a sea full of unfamiliar faces. You look for that one familiar face. And that support person becomes pivotal to perhaps minimizing some of the damage that might occur because of the high stress. And also really thinking about that clear communication as much as possible. Of course, there aren't necessarily always opportunities to go into lengthy conversations about what's happening in the moment, but it's about when that opportunity presents, being able to say, this is what's going on, this is what's happening, helps a patient to feel that they're still involved, that in that partnership, they are a valued and equal partner as opposed to somebody who is occasionally given permission, that they are at the center of their care. And I think it's just also in terms of trying to minimize the traumatic experience for the patient, just clinicians being able to demonstrate an awareness of self. So earlier, I don't remember if it was Penny or Deb who talked about the clinician's own anxieties. So it's a high-stress environment. It's a high-stress environment, right? So everybody's highly anxious. What's our body language saying to the patient? And so even when we are providing those choices, are we doing so but with, an inclination towards a particular choice? Are we still really saying, these are all your options and any one of them is okay? Or are we starting to say, in my clinical experience, this is what this looks like. And is that being interpreted as this is the decision that I want you to make? And I think those things really help patients to feel heard. And we're really just thinking about, particularly in emergency situations where, like I said earlier, having those lengthy conversations can be difficult. Just being able to actually provide a bit more information where you have those micro moments to do so, but also being honest. Because the relational piece we talked about earlier on, and I continue to emphasize, is about that, honesty. It's about saying, fully appreciate this might be the decision that you're making. The reason, I think that might not be the best choice is for these particular reasons, and pegging it at where the patient is at. The research tells us, these are the potential consequences of that decision. However, it's still your decision and your decision to make, and being clear about that. But also something that I think sometimes gets overlooked after sort of emergency situations is the debriefing and that psychological support afterwards, because I think there's overwhelming emotions, not just for the clinicians, but for the patient. And sometimes they're left with a mixed bag of heavy emotions that they now have to try and process themselves. And I think sometimes just being able to sit down with the people who were involved and having a debrief about, so this is what happened, and you may have a lot of overwhelming emotions at the moment. You may want to talk about it. And if nobody's qualified to debrief, here are some referrals. Here's how we can get you the help that you need, because we're realizing that this is something that might stay with you for a really long time.
Deb, how do we balance providing enough information for informed decision-making without overwhelming patients, particularly during these time-critical situations?
The honest answer is trying to, in a time-critical situation, it's never an ideal situation. I just want to pick up on a point which actually is relevant here. So one of the things that I do working in antenatal care, and it is that ongoing conversation, not as a one-off thing, but as I said before, in terms of, what does consent look like? Having women and partners understand that. The other thing which I really want to speak to is actually letting women know, giving them permission that having birth, making decisions and consenting especially if it's in a time-critical situation or just really being in labour. And I was sort of thinking of an analogy. Say you go to bed with a tummy ache and then suddenly all these people come rushing into the room and whiz you off in an ambulance and take you off to have your appendix out, and you're having to sort of process all of this. It's a bit the same if you're in good labour. And one of the things that women talk about in my research all the time, suddenly all these strangers came rushing into the room. When all these strangers come rushing into the room, actually what will happen to the woman, going back to the neuroscience of it, is that you've basically just got the flight-fight response going on. And so actually not much is being processed. So in trying to have a conversation consent, so what I like to do is prepare women and actually say as part of their birth planning and whatever, which is, Penny was actually talking exactly about this from the perspective about making sure that you only have the people that you need into the room, but really understanding the physiology of it, why you don't want all these strangers coming rushing into the room. The other thing is, and we forget about, is, and we're actually moving into talking about trauma rather than consent, but it actually does, and that's a bigger conversation for another time. But warning partners, we get used to blood. We really are used to seeing a lot of blood. Most partners have never seen blood like that before. And so actually warning them. So not instead of, because that's important, but letting people know it's overwhelming. It will feel funny. It's not abnormal to feel funny. So when something like that got happening and they're feeling like, oh, this is horrible, they can go, oh, that's right. This is a normal response. It's a normal response to an abnormal situation for them. So I just really wanted to kind of make that point. I'm with somebody else, we were sort of looking at doing like protocol for trauma-informed codes. So that known person is as important as the drip, nearly, if you know what I mean. Having that safe person that's there. And then the other thing is, which you said, Penny, one person talking in a calm way that really reinforces. So that's what helps everybody in the room feel calm. The person who the woman knows the very best should be with her. And so these are the kind of things that can help create that safe, calm environment. I guess it just really comes back to that. Your own reflexive practice, everybody stays calm. If you've got so the amygdala thinks there's an adult in the room, thank goodness. But hopefully the groundwork has been laid. And as I said, I cannot reinforce this enough. One should hopefully never be in a situation where you've got a stranger coming in who doesn't know anything about the woman who's providing consent. That is really, we should be doing everything in our power, working together, so that's never the case. And I know that that's aspirational, but I don't know that it's completely... I don't think it's something that we can't achieve. We just need to be thinking about it. It just needs to be something that's uppermost in our minds.
In maternity care, obtaining informed consent is often shaped by multiple conversations with midwives, obstetricians, and other members of the care team. And sometimes patients may receive different framing or recommendations from different clinicians. Penny and Deb, how should multidisciplinary care providers work together to maintain trust and ensure patients receive consistent and clear information throughout their care journey?
Creating a safe environment is fundamental to maternity care. And when a woman and their partner feel safe, supported and listened to, that shapes how the conversation can occur. When I say united front, we bring different things to the table. And so midwives, we sort of think of ourselves as, as experts in normal, but we also need to know with being that sort of potentiating the best possible physiological situation. But we also have our colleagues who are here who are about, thinking about, what's risks, the contingencies, when do we escalate, what's the right time, and getting that right. Working together it's the most important thing that we can do. We never want a situation, well, I personally very much argue about the point of that sometimes there can be a bit of gatekeeping, the midwives, protecting the woman. That creates a very unsafe environment. It should never be that we need to keep this gatekeeping, and I do bang on about it a lot because I think it is just the most important thing. We should be working together. We should not be contradicting each other. We both should know what's important to the woman and we should be able to have a conversation, but the woman should be at the centre and we bring what we bring. But women, I mean, as a woman myself, having had 3 children myself, and I think, Yvonne, from what you're saying, is that you want to feel safe. You want to feel that the team is working together for the greater good of the mum.
Absolutely, Deb. I think good communication between staff, and what really this reflects is the whole birth suite safety culture. So, psychological safety in the team so that if people see things that are not going well, they feel safe and supported to speak up. I think lots of work should be done on teams, and especially in our public hospital system, so challenging with staff turnover and things. It's key, though, to try and still keep a sense of united team front. Right? It's very interesting, the idea of birth suite safety culture. And if services would like to try and measure how well they're doing, there are a couple of Australian validated tools that can be used. The Measuring and Monitoring Respectful Maternity and Newborn Care, so the Mothers on Respect Index, the MORI, a validated survey, Mother's Autonomy and Decision-Making Scale, the MADAM. So I strongly encourage services and practitioners to go out there and try and see how safe, try and measure how safe their women feel. That might give some really good feedback and some more improvement work that can be done because the birth suite safety culture is critical.
Yeah, excellent. Yvonne, do you have anything to add?
I think ultimately patients just really want to feel heard and understood. I think from a patient perspective, trust is built or broken by how well the team communicates and works effectively together. And patients will notice very quickly when their care is inconsistent and fragmented. And those cracks that Deb was talking about will show up pretty quickly. And what that does to the trust, it really starts to rupture that relationship, because now can you really trust the people in front of you when they don't seem to trust each other? Even I think when opinions differ, it's important that the patient is understanding the difference in perspective and where that's coming from. So again, really that clear communication and really ensuring that ultimately the patient is feeling that they are at the center of their care and that everybody is invested in this one goal, which is to deliver their child safely.
To finish off, do you each have a key takeaway for our audience which you would like to emphasize from today's discussion? Penny?
I'd just like to add about the birth suite being the coalface. It is hard, and we sort of alluded to vicarious trauma for staff, and I'd like everybody to have a think and take stock of your own mental health.
Thank you. And Yvonne?
I think for me, the three main words I would really encourage everybody to take away are relationship, humanity, and humility. And I think those are the three principles that will underpin good consent and a good experience for a patient.
And Deb?
And I think mine is simply, when women feel safe, listened to, informed and supported, even in complex or urgent situations, we strengthen both consent and trust. And that is our mandate, I think. We need to really have women trust, put trust, and I think it's really well earned. We are working towards a really safe, trusting environment where women can come and feel listened and heard to, and I think that's what we are all united here today, I think, in saying that.
Penny, Deb and Yvonne, thank you. It has been a great discussion. You can find the resources discussed in today's episode via the link in the show notes. If you enjoyed this episode, please rate, review and subscribe and share. And don't forget, RANZCOG members can log into CPD hours for listening and answering the questions using the form attached in today's show notes. We'll be back soon with more conversations on Talking O&G. Thank you.